Hi, Dr. Grossman, how are you? Thank you for joining us on the Beating Melanoma project. And we have a really, really great treat. We have another national world expert on the topic of melanoma. And Dr. Douglas Grossman is actually an MD PhD. He is the professor of dermatology at the University of Utah School of Medicine. He's also the investigator in Huntsman Cancer Institute of the melanoma program. He has a strong interest in sort of taking care of patients with high risk for melanoma. He has been directing the MOSE mapping program at their Hugh Huntsman Cancer Institute since 2004, in addition to seeing patients and writing papers, and he also has a very active lab research. So welcome, Dr. Grossman.
Thank you.
So couple of things. I really want to talk to you about, your expertise, some of the work you've done on genetic profiling. But before we get to that topic, maybe you can walk us through a little bit about, what is your clinic like and what is this MO mapping program?
Sure. We focus the clinic on patients who are at increased risk for melanoma. And that can include patients who have had a melanoma, patients who have family history of melanoma, as well as patients who may not have had melanoma, but they have other risk factors, such as multiple nevi or moles, or we call atypical nevi. These are moles that are more irregular, larger, and ones that need to be followed closely. In addition, we'll also see patients that have other genetic predispositions. They may be known to carry mutations in CDKN2A, for instance, that might have been discovered through genetic testing because of other family histories of different types of cancer, and other rare mutations that can also be found incidentally on genetic testing, that might predispose them to melanoma.
Now, when you working with those group of patients, is there a certain number of nevi that put them at the higher threshold? Like is it 20, 30, 40s?
Well, in terms of a risk for melanoma or in terms of who we would do photography for, we could sort of answer those separately. I think it's interesting. I'll see a lot of patients who have had melanoma, and looking at their skin, you wouldn't necessarily predict that they were at risk for melanoma. They don't necessarily have a lot of nevi. They may not look like they have a lot of sun damage on their skin, but many patients, though, will have numerous nevi, other features of sun damage. They may have history of tanning bed use, for instance. And so there's really no specific threshold or criteria for use of photography other than it's if I think the photographs will help me and help the patient monitor their skin. And so, if the patient only has a few atypical nevi, but they're in a location that, let's say on the abdomen or the face, they could easily be monitored. Maybe the patient doesn't necessarily need those photographs. Most patients, many patients have them on the back in areas that are hard to monitor, though. And certainly, I think if you have more than 50 nevi, then it's going to be hard to follow those without photography. And so, those are sort of the general guidelines. But basically, there's no point in doing the photos if the patient isn't committed to returning for follow-up and to using the photographs at home. We know that in our experience, about half of the melanomas that we've diagnosed, the patient noticed something, and then they came in. But about half the time, the patient was unaware that they had a melanoma on their skin. And so I think there's value in both having the patients monitor at home with the photographs, as well as coming in periodically and having us do it with them.
No, I completely agree with you. I mean, I think I have the same approach, right? And we use total body photography as well. And one of the things I think the patient always have trouble in sort of, they get very nervous about doing the self-exam because they don't know what to look for. I always tell them, if you have a baseline photo, look for change and look for comparison. And then I totally agree. I think we're on the same page. And one of the things we're doing here is, when I was at Sloan Kettering, we had this 3D photography system, and we're actually going to implement it here. So, and I think we're doing the same thing. Now, just shifting gear a little bit, because this is what I really want to talk to you about, genetic expression profiling, and how is this technology being used in diagnosing and managing melanoma. And before we even jump into that topic, maybe you can explain to the audience what exactly is genetic expression profiling?
So genetic expression profiling really involves a test looking at the melanoma tumor. So the primary melanoma tumor, once the patient has had a diagnosis of melanoma, that tumor has been removed from that specimen from which the diagnosis is made. Sections are cut and put on a slide, and from that material, RNA is isolated. This is genetic material that's encoded by the DNA in cells that specifies protein expression. And the RNA is analyzed using a specific assay called polymerase chain reaction that's specifically designed for specific genes that have been predetermined to be correlated with high risk of melanoma metastasis. And so essentially what you're doing is you're looking at the patient's tumor and assessing relative expression of a finite number of genes ranging anywhere from 8 to 30, depending on what test you're using. And then based on the relative expression of these particular genes, a risk score is developed that correlates with risk of metastasis.
This sounds, from the layman's perspective, right? And this sounds really exciting, cutting edge. Does this work? How good is it?
Well, I think it does work. And the challenge is figuring out, first of all, it's a very expensive test. It costs thousands of dollars. And so it's not a test like a simple blood test that may only cost $100 that, maybe there'd be no harm in getting sort of additional testing. This is a test really should be carefully considered. And you have to also consider the potential pitfalls. So with any test, there can be a false positive or a false negative. So in other words, there's always a chance with a test result that it might underestimate the risk of metastasis, in which case it might give you false reassurance. There also would be the risk of overestimating the risk of metastasis, in which case it might create undue anxiety for the patient. So these are things to consider. And I think I would just take a step back and sort of, tell you a little bit about sort of what was the reason for developing these tests and what's our need for them. We currently have very good melanoma staging systems based on over 50,000 patients with their tumors and their clinical information. And so we can very well predict, simply based on the depth of the melanoma tumor and a few other of the factors that would be in the pathology report, what that patient's risk of metastasis, recurrence of metastasis, and death would be. However, we know that there are patients who have very thin melanomas that would be predicted to have low risk of metastasis that ultimately do have metastasis. And conversely, other patients that have a positive sentinel node biopsy or a deeper primary tumor, and they actually end up doing okay. So within our current staging prognostication, we know that it's not perfect, and there are patients that fall through the cracks in terms of our prognostics. And so we'd really like to know if we could, identify those patients with a molecular test who might be at higher risk than we might otherwise predict that they would be, and maybe we would more carefully surveil those patients. Similarly, there are a lot of patients who get aggressively treated for melanoma, and maybe they don't need such an aggressive treatment. Maybe they don't need a sentinel lymph node biopsy, most of which that are performed are negative. And a lot of patients are treated for with what's called adjuvant therapy. So they're given immunotherapy because they're at risk of recurrence, but at the current time, they actually don't have known metastatic disease. And so if we can identify which of those patients maybe could be spared a very toxic and expensive therapy, that would be good as well. So that's kind of the backdrop. And so several companies have developed these tests, and they've gone through various stages of validation. Maybe I'll stop there and ask, let you give your next question. But I could go on in terms of sort of going to some of the pitfalls and problems with the tests.
No, I think let's step back. Maybe no, this is a perfect explanation. Give the great background. The reason why those tests come about is I think some of the statistics that we should mention is about 3 to 5% of thin melanoma that can have eventually metastasis spread to the lymph node, etc. And when we talked about sentinel lymph node biopsy, about 5 to 7%, of those patients that can have similar type of meds issues, and that's why the genetic expression profiling, this new technology, is sort of developed, right? And to help us to sort of fine tune the prognostication. One of the things is that maybe we come back that I know that there's different companies and have their different assays. And one of the company, the leading company out there is, taking the tumors and helping you sort of predict whether there's something that is going to go to the lymph node or not the lymph node. Maybe we can use that, and maybe we can just use maybe a case that you've experienced, and maybe something that worked or something that didn't work, so that maybe we can use that case study to showcase potential, the benefit and possibly the pitfall, like the false positive, false negative, everything you just talked about.
Sure, and the problem is that all these tests have been validated on groups of patients, but they really haven't been compared to each other or really evaluated in the context of how much value they add over existing parameters. And another important thing to consider is, what is our clinical threshold for intervening for a patient? So let me explain what I mean by that.
Sure.
Let's say that we're trying to decide if we should be more aggressive with imaging surveillance for a patient because they might have a higher risk of metastasis or recurrence. And our current parameters say that this patient has a 10% risk of recurrence. Let's say the addition of a gene expression profiling test might be more accurate or might improve that accuracy. And maybe it would show that the patient has a 12% or 13% risk. But is that enough of a change to change my intervention for the patient? So, and every physician's going to have, this is going to be different, but we have to think about, what is your clinical threshold for doing something different, either giving a more aggressive plan of treatment or monitoring, or withholding something that might be FDA approved for a patient based on simply a molecular test. And so it's clear that these tests add prognostic value, but it's not clear how much more value they add, and whether really it depends on different clinical scenarios, whether it would change or meet your clinical threshold for changing management for the patient. And so what none of these tests have done yet is shown in a clinical trial that that there's benefit to the patient. So in other words, could you take a group of patients and randomize them to a particular treatment or surveillance based on a genetic expression profile test, and then because you do that, then ask, did those patients benefit? And that's what we don't know. In other words, by being a little bit more precise with the prognostication, we don't know if that's enough to really make a difference or not. Because if it doesn't, then it's not worth the cost. And as I said, there's always the risk of false positive and false negative tests, in which case you might be harming the patient by doing something based on the test result. So I think that the future is bright for these. We always want to try to offer new things for our patients, and we're in the molecular era where we can get so much more information than we used to be able to get from patient tissue. But I think we have to tread carefully and be sure that before we start using the test result for patient management, that we're sure that we're doing it in a way that we know is going to benefit the patient.
What do you say to, so let me give you an example, right? Let's be more concrete about this. So everything you said, I completely agree. And let's just sort of give you some, for the viewers out there. Let's say you have a patient who had a melanoma 0.4 millimeters in breast cell thickness, right? So if you go with the AJCC criteria and you will not recommend any lymph node biopsy, you will not do anything of those sort. And now this patient, let's say, is super anxious, let's say, and now I've seen that a lot, right? And they start asking a lot of questions, and they see other local community dermatologists. And I seen this test, genetic test, is being ordered on this group of patients because they're just super worried, right? And but in most cases, like pretty much like maybe 99% of the time, the test coming back perhaps is just going to tell you this is benign in a sense. Is there a value here to basically give some sort of psychological, emotional relief for that stressed out patient?
Well, there would be if you knew that you could have 100% reliability in the results of the test. The problem is that, particularly for early stage tumors, the tests are not as accurate. The performance of the test improves with the thicker the tumor, and that makes sense because the more that a tumor grows, the more likely it's going to be expressing those genes to fulfill its metastatic potential. Whereas when the tumor first starts, maybe it might express those genes, or maybe it doesn't, and maybe it hasn't really fully developed yet. And so, these are just things to consider. Like I said earlier, is that yes, you're likely to get a negative or low risk result, but you might be giving false reassurance to your patient in doing that. Some of the studies that have been published have shown that some patients with very early stage tumors who metastasized, the test actually didn't predict that. And it did predict metastasis in some patients who didn't metastasize. And so, this may all change. I mean, over time, some of those patients that had not metastasized, maybe they would down the road, but, during the period of follow-up, they didn't. And so I just think it's still sort of a gray area, and it's not clear how much extra value that test result would give over other clinical pathologic factors that you would already have available from the pathology report.
So I'm going to push you even a little bit harder. I know that this is a very, very controversial gray zone area. And that's why I'm going to try to give specific examples, try to push you harder. And let's use another case. So obviously we used the earlier case, the 0.4 millimeter. That's definitely just see no value in here, right? But let's just say, you got
let me just continue with that scenario, and before you go to the next one.
Sure.
So this has happened to us.
Okay.
They have a 0.4 millimeter tumor. And so we recommend no sentinel lymph node biopsy. But maybe they go to another dermatologist and they run the test, and then it comes back as a high risk result. Then what do we do?
Yeah.
The answer is we don't know. This patient group has never been studied. And so we just don't know. And, do we do something more aggressive based on that result? The fact is, what we usually do is we discuss that patient in our tumor board and just get a consensus opinion and basically tell the patient we don't really know what to do. And sometimes we compromise, and maybe we just do a little bit of imaging that we wouldn't normally do. If they really want to get the sentinel node biopsy, then we can do it. But we just don't have data, a track record to look back on and say, well, it really wasn't worth it to do it in that case or not. And that's what we're faced with. So I don't personally order the test because I just don't feel like I really know yet what the best scenarios, to use it for the patient. But often the patient has the result and then comes to us, and then what do we do? So it puts us in a difficult position.
Because
And
you are the one of the tertiary referral center, and this is a kind of a quandary, because just for clarification for the everyone out there, the public looking at this video, that is the criteria, one of the criteria for doing lymph node biopsy is, if you have you offer the lymph node biopsy if you have breast cell thickness, melanoma thickness greater than 1 millimeter, right? So obviously if it's less than
point 0.8 now.
and with or without ulceration, this is 0.8, you start sort of recommending, you start talking about it, but 1 is definitely a clear cut.
Right, but I mean, those parameters are based on the risk of having a positive test result.
Sure.
And so if we think that the chance of having a positive sentinel lymph node is less than 5%, then we generally don't recommend the test. And in general, in medicine, we don't recommend doing a test if the chance of it being positive is less than 5%. That's kind of a, just for a lot of areas of medicine, that's kind of what people go with. But the question is then, if the test result is positive, the GEP test, does that then raise it to a higher, above that 5% threshold, where then it's worth, doing the test, doing the sentinel node biopsy?
So obviously this is an example of not false positive, but you just don't know what to do with this extra piece of information, basically, right? And then that's why it puts the patient and your team in a very difficult situation, because no one have the data at this moment. And a lot of times when we're thinking about the best practice of medicine is, anytime you order a test, it should not be a knee-jerking process. You should be thinking about, when you do this, what are the downstream management plan you're going to do? If you're not going to act on it, you perhaps should not order that test, basically.
Well, exactly. And so I totally agree with you. I don't think we should order a test unless we know what to do with the result. And since we don't know what to do with the result, then I'm not inclined to order the test. I come back to, I think it would be simpler if it was a very inexpensive test, and if the sentinel lymph node biopsy was not an expensive operating room procedure. Then you'd say, well, what's the harm? If we're, no one's using this test to decide, for instance, what should be the margin for your melanoma excision or something.
Sure.
Where it doesn't really make a difference if you did 1 centimeter or 1.5 or something, then you say maybe the test really could help us. Yeah, but here you're talking about a test that's $7,000 or $8,000, and someone's paying that. If it's not, the patient's insurance, that someone is paying that. And then to undergo a sentinel lymph node biopsy, for which there can be some complications sometimes, and it's an expensive operating room procedure. So, the stakes are high when you act on using these tests, I think.
So before we moved on, so I think we sort of talked a great deal about this. Would you ever, in any other circumstances, order this test? Let's say if the breast cell thickness is 0.8, let's say, right, transected at the base or something like this. Would you order it, or at this point you still basically says you would not?
I just don't have, I don't have any experience or from looking at the literature to say that it really would make a difference. My approach, I have different clinical approaches for these other scenarios. So if someone who comes to me with a transected melanoma, or let's say I biopsy a lesion that I don't think is a melanoma, and so I think it's a non-melanoma skin cancer, and so I'm not trying to do a deeper biopsy. I just get the top of it. It comes back as melanoma. Then I bring the patient back in and I re-biopsy again. And then there's studies showing that you can look at the second biopsy and decide whether that was the extent of the first biopsy, accurately showed the extent of the tumor. And then you could decide what to do. So I think there are workarounds for some of these things that you don't need to rely on a test like a GEP to help you make a decision like that. But, as you said earlier, there are these 3% of patients with very early stage disease who do recur. And because early stage melanomas are so common, they actually represent about a third of melanoma deaths. So if we really could precisely identify those patients, that would be great. And maybe we could make a dent in that, mortality number. But right now, it's not clear that the GEP tests can do that.
So the bottom line is this is a very promising future, and at this moment that we don't have enough data, and hopefully down the road, as science progress and research gets refined, and we hopefully can use it in clinical practice with much.
I mean, I would just say as a final comment that, I mean, these tests were generally developed to predict metastasis, specifically distant metastasis. But I think the more immediate application is going to be, as we said, prediction of positive sentinel node.
Yeah.
And there, I think, the clinical studies can be more easily interpreted because the sentinel node is either positive or negative at the time you test it. Whereas you never really know if the patient is going to have metastasis or not, no matter how long you follow them up, because they could still recur 20 years later. And so you never really know. Whereas I think for a sentinel node, you know what the result is. And so if you look at enough patients and enough GEP tests, you'll be able to really see how well do they predict that. And so, maybe 5 years from now, we'll be doing that more routinely to guide us to hopefully spare more patients from getting the sentinel node rather than triggering the procedure. Because as you said also, most sentinel node procedures have a negative result. So we know that a lot of those patients actually didn't need that procedure, but we just don't know
which one exactly.
Trying to figure out which ones. Yeah.
And I think your assessment is in line with the NCCN guideline, right? And I think also the AAD guideline is basically saying the GEP testing is not part of the mandatory, recommended workup at this moment.
So what's happened is the guidelines say a couple things. One, they say that you should use that there are multiple. Well, they first say that you should treat your patients based on their risk. And then secondly, they say that there are multiple ways to assess the risk, including GEP testing. But what they don't do is link those together, which some of the companies have done in their marketing, and say that the guidelines recommend that you use the testing for patient management. And so that third piece hasn't really been, substantiated yet, in my opinion.
So we talked a lot about, you actually biopsy the specimen and then decide do the GEP for predicting mets or lymph node. But I know there's another company out there, and that basically you put the tape strip of the moles and then try to tell you whether or not something that should be biopsied or not biopsied. What is maybe you can explain a little bit about that technology and what is your feeling on that, basically?
Yeah, that's the pigmented lesion assay from DermTech. So that's a diagnostic test. So it's trying to help you decide, should you biopsy a lesion or not? How likely is it to be a melanoma? Whereas the GEP is the diagnosis has already been made, and it's trying to help you predict the risk of metastasis to then do something, for the patient. So the tape stripping, it's a very innovative, easy to use technology. It does have a few pitfalls. First of all, you don't get a result immediately. It takes about 4 days to get the result. So you apply the adhesive tape and then you send it to the company, and then it's a couple days to get the result. So the patient has to then go home, and then if it's positive, you then have to bring them back to do the biopsy. Which I'm in Utah, and some of our patients drive 5 hours to see me. That's not going to be so practical. Advantages of the test: it can be done remotely. During COVID, a lot of patients didn't want to come into the clinic, and maybe they had a lesion that they were concerned about, and you can arrange to have the test sent to them and instruct them how to use it, and then they mail it in, and then you get the result, and then decide if the patient really needs to come in or not. The ability to detect melanoma is pretty good. So the test is fairly sensitive, but in some cases, it's not always very specific. And so it might lead you to biopsy lesions that you wouldn't otherwise biopsy. And so I think in my clinic, if I have a patient who we're monitoring with total body photography and looking for a change in a lesion based on that system comparing to a baseline photograph, to me, that's I find that more reliable than a tape test. But if it's a new patient coming in, or you don't have any photographs to refer to, I think it's reasonable, particularly if there's a lesion you're not concerned about, but the patient is concerned. It can be a very good way to reassure the patient that the lesion is okay. It's been shown that the test has a very good negative predictive value. So if the test is negative, there's a 99% chance it's not melanoma. And so if you're not worried about the lesion, but the patient is, you could tape strip it to get the negative result and then reassure them. Always with the caveat, they still need to monitor the lesion. And if it does change, they still need to come back to you. But if the test is positive, then it's not always melanoma. So it might cause you to do more biopsies.
So, yeah, that's what you mean about it's very sensitive, but
yeah, and so I think you have to decide, in your practice and for what type of patient the test might be most appropriate. I'm not sure it's ready for primary care. The test was developed and tested on high-risk patients for lesions that were suspicious for melanoma, and then to start putting it on seborrheic keratoses and lentigos and things that, or other things you might see in primary care, not knowing what you're dealing with. We haven't really studied it in that clinical setting.
Yeah, I think the prevalence.
So I think you have to think about sort of how it was developed. And
no, those are very, very. I mean, I think I use. You and I sort of worked in the same way, right? We're using total body photography, we're using dermoscopy, we have a certain way of tracking them. But I agree that, I think those tools are very, very valuable. If I see something that I'm, really concerned about, the probability of this is a severe atypical nevine melanoma, or it's pretty high up. So the diagnostic accuracy is pretty high. But I think it is kind of useful sometimes for patients, especially young women on the cosmetically sensitive areas such as the face. They don't want a biopsy, and this is a one way of sort of bridging that process.
Yeah.
Well, Dr. Grossman, I really, really want to thank you for your time. We can sort of sit here and talk about this stuff for another 30 minutes. We didn't even touch upon your lab work, because I know you have some innovative reagent or agent that sort of have a chemopreventative effect and protecting against the skin cells from developing cancers. Now, hopefully we get a chance to interview you again in the future. Thanks again for your time.
Yeah, it's been great being with you. Thank you.
Okay. Thanks again. Bye-bye.
All right. Thanks, Steve. We'll see you.